Pahlajani, Dep, Head of Interventional Cardiology at Digimed Hospital, Mumbai. And I happen to be also the past president of the Cardiological Society of India. Before I start my introduction of my topic, I would like to congratulate Dr. Parthasarathi Banerjee and his team, which has lined up an excellent scientific program for this Cardiological Society of India annual meeting. I wonder how he has been able to get such a wonderful international faculty. The topics that he has chosen, they are really current, modern, and contemporary. So please accept Dr. Parthasarathi Banerjee. Please accept my congratulations. Actually, he has given me a topic which is really very contemporary and which is new. He has asked me to speak on the evaluation of chronic coronary syndrome. As a matter of fact, this is a very new terminology which has been coined by the European Society of Cardiology 2019 and which has been adopted by most of the societies all over the world. This terminology has done away with the old terminology, what we used to call as a stable coronary syndrome or stable ischemic heart disease or stable coronary angina or angina. In this, there are several different syndromes of coronary artery disease clinical features which occur from time to time. Previously, we used to think that the stable coronary artery disease is sort of a stable, becomes acute coronary syndrome, becomes acute myocardial infarction, and then it remains like stable like that. But it's not so. Actually, the course of the coronary artery disease is sort of in a curved and in an undulating fashion. Today, patient is stable symptoms. Tomorrow, he becomes acute coronary syndrome. Day after, he develops acute myocardial infarction. The plaque actually organizes, the thrombus organizes, the recanalization occurs. Patient develops stable symptoms. Again, at some time, patient again goes into the same group of symptoms from time to time. In other words, the disease is permanent. The atherosclerotic disease is permanent, it doesn't go away. Now, in this, the European Society of Cardiology has given different steps to investigate and evaluate the patients, which starts, as a matter of fact, any coronary artery disease patient. The first step is to evaluate patient's symptoms and categorize him in one or the other forms. And we all know what are the classical symptoms of angina. Then we know who are the high-risk patients who are likely to develop acute coronary syndrome. When a patient develops acute coronary syndrome and acute myocardial infarction, we categorize them as the high risk or the low risk patients or intermediate risk patients they're going to develop a recurrent episode again, because the risk of developing ischemia, infarction, death does not disappear. There is always, in the first year, there's always a risk of developing the similar symptoms, losing lives in the first year after acute coronary syndrome or acute myocardial infarction. So in other words, there's a permanent risk. And in this risk, we have to categorize the patients into high, low, and mid intermediate risk to control risk factors like diabetes, hypertension, cholesterol, smoking reduction, weight reduction, exercise program, to look after the patient's BMI. And then, of course, the drugs, which will sort of lower the patient's cholesterol, achieve the targeted cholesterol goal levels as advised by the various societies. Then, of course, the patient will be then on antiplatelet drugs after the procedure has been performed, like PCI or acute or coronary artery bypass graft surgery. Patients are usually on aspirin or clopidogrel or the ticagrelor. Patients should be continued. And the most important is to watch for the another acute episode and prevent another acute episode and death. So I think these are the main goals which are lined up in the new guidelines. The other guidelines are whether the patient should go to diagnose coronary artery disease, patient should go for myocardial perfusion scans, or go for the CT coronary angiography, or go for the straightway for the coronary angiogram. I think this will be determined mainly by the patient's symptoms, ECG findings, the echo findings, and stress test. And the patients who are likely to be, even asymptomatic patients who are likely to be high risk by the various criteria. The prevalence rate of coronary artery disease in such group of patients is there. Those patients can go for a stress test or myocardial perfusion scan. And once the myocardial perfusion scans are positive, then the patient one can decide if the patient should go for the CT coronary angiography and coronary angiography. Even in the coronary angiography, to evaluate a patient properly, one has to do some additional tests in some patients' coronary arteries where the lesions are borderline, and borderline lesions need additional investigations by performing an FFR or doing an OCT or IVUS. Because we see several patients where lesions look very mild, and you do an FFR, you find that the FFR is significant, is less than 0.8. And of course, these patients need an angioplasty. So I think in FFR guided angioplasty can be performed, or the IVUS guided angioplasty can be performed to achieve the good results, and also find out the patients in whom we find that the lesions are borderline. But actually, they're not borderline, because there is some kind of a discordance between our eye evaluation and the actual existence of the disease in the coronary artery disease. So I think wherever borderline lesions are there, we always like to do an FFR or do an IVUS or an OCT and then decide. Because it is found out by the Swedish study that within next 7 to 8 years' time, it is the non-culprit vessels which were found to, which were labeled as non-culprit during the coronary angioplasty for acute coronary syndrome or myocardial infarction, which actually produced the next episode. It is that kind of incidence is twice that of the patients who develop an acute coronary syndrome or acute infarction due to the occlusion of the treated or the stented vessels. So I think one should not disregard non-significant lesions which appear to be sort of to the eye of less than 70% of the lesions, and they should be further investigated and do an FFR or an IVUS or OCT. This also helps us to achieve the optimum sort of a results of performing an angioplasty, to see whether you have achieved a good apposition of the stent to the vessel wall, because the malapposition can cause stent thrombosis in the acute phase or in the long run. So I think achieving a good apposition of the stent to the vessel wall, especially the left main situation, the IVUS would guide the angioplaster to perform an optimum angioplasty and get the best of the results. I think these are, in a nutshell, the guidelines which have been sort of given by the European Society of Cardiology. And I think this is how one should evaluate in 2021 a patient who suspected or where you suspect coronary artery disease, and also evaluate the patients further who have undergone angioplasty due to acute coronary syndrome or myocardial infarction, and also evaluate your coronary arteries more optimally by the added tools like FFR and the IVUS. And I think this should be the approach in 2021. Thank you very much.